We've all been lied to. For decades, we've been taught that having crooked teeth or crowding in our mouths is the result of bad luck or bad genes, and it's a problem with purely aesthetic consequences. But now there's a small group of pioneering orthodontists who are using evolutionary biology to challenge some of those long-held beliefs, and they're making waves. This week, I got to sit down with Dr. Sandra Kahn, author of the book Jaws, The Story of a Hidden Epidemic, to talk about the actual origins of crooked teeth, the health implications of not having enough room in our mouths, and most importantly, what we can do about it. Let's get into this. What I wanted to start with is this really interesting quote from your book by an evolutionist named Richard Klein. He says that he's never seen an early human skull with crooked teeth. And yet in your book, you also say that 50 to 70% of children, and I'm guessing this is in the United States, get braces between the ages of 6 and 18. So how can we have those two things coexisting, where on the one hand, we have no early human skulls with any evidence of crooked teeth, and yet as much as 70% of children nowadays presumably have crooked teeth?
Well, it's not anybody's surprise that we've changed our lifestyle and our habits. And we even have what we call Western disease or disease of modern life. And, we have obesity. And obviously, when we were hunter-gatherers, we didn't really have the ability to become obese. Our genes are from the cave time, and our diets, our lifestyle habits are from the McDonald's. Modern industrial world. So we have that which Paul calls the mismatch, where our genes are not living in the right environments. So whatever expression of our biology we see is something that's not necessarily the ideal, because we've changed the environment. And I did publish the paper. I don't know if you've had a chance to look at it, because very easy to write a book, even though my book is very well referenced with science and people like Richard Klein, which is probably the person that has held more dry skulls in his hand than anybody else alive. But our article, which was published in Bioscience, that's the definitive article published with 3 members of the National Academy of Science. And we looked at all the evidence, and it took 4 years to get it published. And it really is a definitive paper that says malocclusion is absolutely not an expression of our genes. It's an expression of the environment that has changed.
That's absolutely fascinating. So this mismatch idea, which is present in a lot of diseases, you mentioned obesity, type 2 diabetes, metabolic syndrome, all these types of things, and all the things that come with them have been attributed to that same type of mismatch. How does our changed environment and lifestyle influence the arrangement of our teeth?
Well, the arrangement of our teeth has to do with how much space you have. If you have a house and you get, big couches and the house is small, the couches are going to be piled on each other. And the bone, the jaws, is where the teeth are going to arrange themselves. And that's what would be the house. So if the house is too small, you end up with that crowding. So the teeth crowd up, but not because the teeth are too big. It's really because the jaws haven't expressed their full potential growth. So they're not growing enough. They're shrinking, actually, because as we use anything in our body in physiology, use it or lose it. Just if somebody doesn't walk, their legs are not going to develop, right? So if you don't chew, if you don't swallow, if you don't breathe properly, then the muscles don't stimulate the bones to grow. So we have bones that haven't had enough stimulation. They're too small. Teeth are going to be the same size. And when they come in, we even have something we call the 2-into-1, the rule of the 2-into-1. So we have kids that I saw this 5-year-old just yesterday at one of my students' practice, and the girl was 5 years old and had the two first permanent teeth here. And there were 4 baby teeth that they were gone, and you only had 2 teeth fitting. And there was no crowding, but it was 2 replacing 4.
Meaning the other teeth didn't even, were they still
They're
in the jaw?
They're underneath. And she's
Wow.
5, so the expression of the crowding is not there yet. But this is the Dr. Santos, I think she coined that. She tells the parent it's the rule of 2 for 1, right? You have a space of 2 baby teeth, and then you have 1 permanent teeth that takes out the room of 2 teeth.
Wow.
So this just means we're, incredibly crowded, and it's just getting worse. And it has nothing, some people think that we have more access to braces, more available orthodontists, and this is why we're funding more malocclusion, but it's not that. The epidemiology studies, they do show that this is in the increase.
So it's actually that our jaws are physically shrinking, our faces are changing in structure, and we don't have room to fit the teeth that are genetically programmed to be there.
Exactly.
Amazing. So Weston Price was a dentist in the late 1920s and early 1930s, and he went all over the world and studied populations that were in contact with Westerners, and then found people with the same DNA who were not in contact with Westerners. They were like more isolated people living in geographic locations where they couldn't get access to these other people. And he was seeing massive differences in physical structure and health status and the presence of disease in these populations based on availability of nutrients and, shall we say, introductions of things that are toxic to human beings. Is this playing a part in what you're seeing with this crowding phenomenon and shrinkage of the jaw?
Look, everything has an action, and we know that there's many things that have changed in our lifestyle. We haven't really pinpointed exactly what causes the problem, the tipping point, right? But it all adds up to the problem. Weston Price focused a lot on the chemical composition of the food. Mm-hmm. His writings were more related to, are they eating more plant-based or animal-based protein? And obviously, people that were eating meat were chewing more, but he really didn't talk about the way the food was delivered. It was more of just where the source of the food was. Obviously, populations that had more industrial food or processed foods had more problems with crowding. He had, siblings that had moved from a natural environment into some kind of reservation, and the younger kids that moved earlier, they developed crowding and breathing problems and issues. And his photos and his documentation is amazing, because he was the head of the Dental Association for so many decades, I think. And he documented everything, and he traveled so much all over the world. Yeah. So his photos are really interesting. Mm-hmm. It's not the complete picture. It's not the full story. Just like I don't have the full story. And that's why this book that we wrote with Dr. Engelke, we call it Breathe 4.0, because we feel we're only at 4.0, and because there's 4 compartments, but we think there's going to be 4.1, 4.2, 4.3. People are going to build on this stuff. We are not thinking we have the full story. And definitely what Weston Price did helped us focus on other things, especially processed food, not just the way it was, the composition of it, but the way it was delivered to. Because it's not the same if you have really great ingredients and you grind them into a blender and you just drink them, than if you actually chew on the celery or the harder meats or whatever he was talking about.
Mm-hmm. Yeah. So what you're saying is he was kind of the pioneer, and he laid the foundation for people like Dr. Mew and you to come along and keep building on top of it. And with the new book that you're talking about, you're even taking it to a new level.
Yeah.
Very, very
interesting. And we're considering the fact that we don't know the full picture yet, but we have things that we know for sure and other things that are just theories.
Well, that's spoken like a scientist. Well done. So I do want to know, and I'm fascinated to get your take on it because you're an orthodontist. What's wrong with traditional orthodontics? What are they getting wrong?
If you ask me what's wrong with us, it's arrogance. You talked about the fact that you have to be top of your class to even apply.
Mm-hmm.
And to be in the top of your class, you have to be arrogant and you have to, be cutthroat and you have to be competitive, and it's not conducive to having people take their time and think about problems and then solving them. And then the biggest problem, and that's in all throughout medicine and other careers too, is the situation with the expense and the loans. So what happens is that the young people are coming out with such big loans, they can only go into something that's making money so they can pay back. And they can't just reflect on how they could do things differently. So it's killing innovation in every field, in my opinion.
That's absolutely fascinating. I have a patient who is an orthodontist. He had a large practice in San Diego. He told me that when all was said and done, after all of his schooling, he was $1 million into student loan debt. That almost made my head explode, Dr. Kahn, because how could you not feel a mountain of crushing pressure on you to pay back a loan of that size?
It's not that you feel pressure. That's irrelevant. We can all handle pressure. What's really is that your mindset focus you on every mouth, not patient, mouth that crosses through your door. You go, okay, I'm going to find something in my mouth, in your mouth, to pay back the loan this month. What can I find that will help me pay the loan?
Wow. So you're actually looking at the mouth with dollar signs in it.
Absolutely. And we don't think about it in it's not a conscious thing, but it's how we're trained. And the consultants come in and they tell you, okay, if you have so many patients come in and they come in with a sibling or a parent, you can say the parent needs Invisalign and give them a discount at 2 for 1. And if they say, we can't pay now, then tell them, okay, you can pay later, but just get them started. And that's just a whole circle of health for profit.
Wow. So you said there a minute ago, it's killing innovation. One of the things that I found fascinating in your book, there's this line that says that it's rare to find children who maintain their orthodontic corrections into adulthood. That has to twist you up as a clinician to say, I'm doing something, I'm spending a lot of time, a lot of effort, putting the person into often significant discomfort, charging a lot of money, knowing that they're not going to maintain these things. That has to wear on you.
It all is from how it's presented, and we understand that it's the patient's fault.
Yes.
It's your fault if it's not maintained. It's not my fault.
I see.
I told you to put the tongue in the roof of their mouth, which will never happen. And I told you to wear a retainer for the rest of your life, which nobody will wear a retainer for the rest of your life. And then when you lose it or it stops fitting and then you don't wear it because it's not fitting and then it disappears, then you're like, you lost it. I didn't lose it. You lost it. So the profession has helped us justify what we're doing. And it's not necessarily wrong, because if you look at people wearing glasses, I mean, am I going to graduate from these glasses? No, I'm going to use them the rest of my life. And, maybe surgery, but I'm going to get more higher prescription every couple of years. And we know that. So why don't we think about the same with a retainer? And we just present it that way.
Interesting.
If you correct someone early enough, and then you correct the habits that cause the problem, then you will maintain it.
So that's, very, very interesting. So that, I think, is the missing link. It's that the participation of the patient, active participation of the patient in the endeavor.
I'm a huge enemy of blaming the patient.
Yeah.
I tell our students all the time, don't give me Oh, the parents are difficult. There's a great book. I don't know if you've read Switch by the Heath brothers.
I'm not.
I have my students read the Wikipedia page on it, which is good enough.
What's it
Any
called?
book, it's called Switch.
Switch.
They wrote, and they don't pay me. I'm not advertising, but they wrote Made to Stick.
Okay.
Great book. They're two siblings from Stanford. And there's this one book called Switch, How to Change When Change is Hard. And I mean, I don't want to use up your time on telling you about a certain book that I love, but it really explains that it's about motivation. And you have to create the motivation, because they say the rational is the rider and the emotional is an elephant. And the rider will never, ever be able to control the elephant. So you're rational. I can give you all the science in the world. I won't convince you of anything. But your emotional will. And that's a lot of like Simon Sinek stuff, you know, the why and whatever. But it's just really clear that you have to change the path and you have to make it possible for people to succeed. If your patient doesn't do it, it's because you didn't do a good job setting it up properly or choosing the patient properly. Don't tell me the parents are difficult. If they're difficult, don't get the patient started. If you start the patient, you made the choice, and if the patient fails, it's your fault. It's the clinician's fault. But we blame the patient on everything. You know, the patient didn't show up, or the this or the that. And, you know, it's obviously the patients have to have their own responsibility, but the clinicians, and my biggest interest now is in something we call transdisciplinary work. And I don't know if this is where you want me to go in this interview, but I'm doing this huge conference in Spain, and we're doing ENTs, physicians, and dentists, and orthodontists, and pediatric dentists, and pediatricians, and we're doing transdiscipline, which you can look it up. The term was coined by Piaget, Jean Piaget, and it's different than multidisciplinary or interdisciplinary, which is mixing different disciplines. Transdisciplinary means I'm going to jump into your discipline to know what you're doing. Like if somebody says you have, you know, tonsils, I'm going to be able to know what the ENT will, I won't just refer my patients to an ENT. I know what the ENT is going to tell them, and I know what the ENT is going to do, because I jumped and looked at their profession and I learned from what they're doing, and they have to learn what I do. My ENTs have to learn what type of expansion I do, why the stage 1 mu expansion is different than all the other expansions, because it looks the same, but it's not the same. So I get to spend time teaching my ENT. My ENT has to be interested enough to learn what I do, not just to send it and say, you know, take care of this. And transdisciplinary work is really the only way to go, because as you said, from probably your experience with your girlfriend that had Bell's palsy, you go to one practitioner and they say one thing. You go to another one, they say something different. That's right. You go to the third one and nobody's coordinating what's going on.
That's right. Everybody's in their silos with their specialties and nobody's even communicating in most cases.
And I was involved for 20 years in cleft lip and palate panels. And we did work transdisciplinarily because the kids were so sick and they were born with, you know, deformities of the head, the brain, and so we needed to have everybody together discussing the case and saying, well, what would you do about this? And how would you do this? And what timing? And when should I do this? And what's the best time? And we used to work like that. And I think because I was involved in that work, that I decided this is the way we should treat healthy children too. Why do very sick kids get this and healthy kids don't?
So you're saying it's just a better model for treatment because you're getting a more complete view of the situation.
Yeah, because if I work in my transdisciplinary team, I have a psychologist. They're going to tell me, don't get this patient started. They're not going to succeed. And of course, if I need the money, I'm going to start them anyway. But if I'm not in debt and I work for a public hospital, I'm going to say, of course, I'm not going to start him. And the mom was going to say, yes, please start me. And this psychologist said, no, she will beg you, but she's not going to be compliant. And then I will not put this patient through the torture and the aggravation for a failed result. but only if we create these teams.
Yeah, very interesting. One of the things that I find curious about the orthodontic community in the traditional sense is that they talk about that 70% of the population needing braces as a result of the mismatch, but it's a different mismatch. It's a mismatch between teeth size and jaw size, which they attribute solely to genetics. So they're teaching in that circle that our genes are just resulting in smaller jaws and less room. It's just like we're saying this with no evidence behind it and moving on to the next topic type of thing.
Yeah, I mean, it's also a way to cope, both for the clinician who has to continue working and for the patient to accept a less perfect result.
I see.
Otherwise, we would all go crazy. But it's every day I still hear it. You know, I inherited my mom's small jaws and my dad's big teeth, and I'm stuck. So I have to pull some teeth out.
Wow.
And then even after that, people that do have all their teeth, then the wisdom teeth don't have enough room, and they go, okay, now I have to take out the wisdom teeth.
Yeah.
So almost, I would say, 99.999% of the population don't have all their teeth because of the wisdom teeth.
Yeah, very interesting. Talk a little bit about this quote from your book. Faulty delayed treatment in traditional orthodontia, parentheses, is connected to a society-wide fascination with DNA and the notion that it alone is the most powerful actor in human biology.
Look, this is part of, I'm trying to justify or to give more, make it more solid for people to start treating children early.
Mm-hmm.
We gotta get the kids at 3 years old expanded and with the right habits. And when we let that pass, then we start blaming DNA. And of course, we're gonna look like our parents and our uncles and our grandparents and our siblings, but we have the same environment. Even people that we didn't know, but our parents grew up with those other people and they were mouth breathers and we imitated them, and we have cultural ways of eating, and we lived in the same type of climates, and there's all these things that are, in a way, they look like they're inherited, but they're environments in which we all live, and our genes are expressed in the same way, so we look like each other. Obviously, we have traits that are inherited, so we're going to look like our parents. The color of our eyes are going to be similar, and we have different things. We consider, my geneticist says most of life is 80-20 in so many things. And so I now quote, it's 80% environment, 20% genes. Mm-hmm. And we can't change 100% of the environment. Yeah. And even siblings that live in the same house are in different environments, because the firstborn is in a totally different environment than the second, the third, or the last born. Their environments are completely different. They eat differently. Their parents pay attention to them differently. They travel to different places, just like Western Price showed, that the age in which the kids move to the different environment completely change their face. Mm-hmm. So even siblings live in different environments. Mm-hmm. And some things repeat themselves, some don't, but we can definitely control a lot of it if we start the first 1,000 days of the life of a child, like the first 3 years, and then we get them expanded. If we haven't gotten where we are, then if the 1,000 days are not perfect, we gotta correct it right after the 1,000 days. 1,000 days is very critical. And I've designed a set of pacifiers for babies. So we get them in those 1,000 days, we start doing the expansion. So I have the pacifiers that stimulate the tongue, the negative pressure, the expansion, and they can be weaned into the tongue being in the right place at 3 years old, so that then you don't even have to correct anything.
Well, that's absolutely fascinating for me. I have a 1-year-old myself, but I'm very interested in that first 1,000-day time period. Because I think it's very, very foreign for most people, Dr. Kahn, to imagine treating a child that young. Most of us have been trained in this traditional model that we've heard from our orthodontist growing up, and the idea of treating a baby that young seems very strange to us. How would you even know that a child that young needs treatment?
Well, because I tell you they do.
How would a parent know to
I
ask?
told everybody. I said they do. They do. There are no kids that I've seen in industrial society that don't need it. But obviously, if you don't have gaps between each baby tooth, big gaps, then you need treatment. And not everybody, and nobody really has gaps. And even the ones that have gaps have some kind of issue with overbite or tongue pushing between the teeth. I mean, I don't see kids that don't need it in industrialized society. And I mean, I use an analogy that I like. When you want to bake a cake, if you want a round cake, but by mistake you pour the batter into a square mold, but you realize you put it in the oven, but you realize right away, you get it out, you pour it in the right mold, you put it in, you'll have a beautiful round cake. But if you don't realize it right away and you bake it for 10-15 minutes, and then you want to undo it, you will never have a round cake. You will have a disaster. And that's what happens. When the kids, they pass the 3-year mark, the 5-year mark, they're baked. And whatever we do is just patching up.
Super interesting. Excellent analogy. Explain to me the difference between children in industrialized society, who you're saying all of them need correction, and kids from non-industrialized society who don't need correction. What are people doing right in societies that are less technologically advanced than ours?
Well, I don't have a huge sample, but a few years ago when I was visiting Simon Wong, one of my teachers in Melbourne, when I came back, we stopped in Bali. And my kids were young, and they thought I was obsessed and I was going to be taken to jail because I was taking photographs of everyone in Bali.
Yes.
And I couldn't believe their posture.
Yeah.
Have you been to Bali?
I have.
I'll share some of these photos with you, but like I rode an elephant. We went to a rescue place, and we rode, and the Mahout, the driver of the elephant, he had such a beautiful straight posture on the elephant with his feet, holding him. And I said, how do you stay this straight all the time? And he said, well, they're Buddhist. And he said, well, my spirit or my energy has to go to heaven. And if I'm crooked, it will never get to heaven. It will be in the earth turning around. And so in partly it's their religion, but they're barefoot, which is critical for posture. Shoes are the worst invention. They're barefoot. They keep their mouth closed. They walk a lot. They live outdoors. And I saw kids, I can show you, I have hundreds of pictures. I saw kids in the market sitting in like a pile of potatoes, and they were straight with their mouth closed, breathing through their nose. And I took pictures of them because their hips were back and their head was to the sky. I mean, it just said, look. And then I started looking at their teeth. And I said, there are no orthodontists in this town because they would go broke. And I have the tons of pictures, hundreds of pictures to show you, because I was like clicking everybody in their face. And my kid's like, Mom, stop this. But that's the only experience that I've ever had where I've seen a society. And it's not only that it was not so industrialized.
Yeah.
It was more that they had this habits and this meaningfulness or mindfulness, I don't know how to call it, but where they wanted to be straight because their spirit goes up.
Yeah.
And so they're carrying themselves in a way, they're not going to be like, because then where's their spirit going to go?
Yeah.
And their education, it was like everyone, poor, rich, everybody just had a good posture, hips back, feet, even if they had sandals or something. I saw people, when they were working, they would take the sandals off and work without them. And their feet were wide. And it just seemed to me like somebody could do a study there. Probably that's what Weston Price was doing in his time. But I would love to just go and find the epidemiology of what's going on, how much crowding they have there, because I really, at least in the area that I was, which wasn't in the city,
Yeah.
I did not see malocclusion.
Yes. Yes, it's very interesting. So I relate to that very much. I've traveled quite a bit into remote places in the world, and you see this in a lot of places that don't have access to the things that we have access to in the United States. They don't wear footwear. They're physically active all day long. And you see this idea of what normal is in other places. And you start thinking like, wow, they're doing something way better than we're doing. You talk about the story of the hidden epidemic here in your book, Jaws, and you've gone away from traditional orthodontic practice. You're advocating treating earlier. You're talking about these things, making sure that these very young children have spaces in between their baby teeth, making sure that their tongue is at the roof of their mouth and they're breathing through their nose. But you tie it here, this health epidemic signaled by reduced facial attractiveness. Explain that part of it.
Look, this was the part that was the most controversial when we were writing for Stanford. Mm-hmm. They really didn't want us to talk about attractiveness, but there is a link between being attractive and health because of if things are balanced and things are working right, you will tend to be attracted. It will, your eyes will recognize this, and it's definitely an evolutionary advantage if you are going to mate to find somebody that has the best chance of producing a better offspring. So if you breathe well and you sleep well, you have a better chance of having a healthier offspring. So if you have bigger jaws, your brain tells you, this is somebody that's breathing better and it has a better chance of, procreating. So certain traits should be selected for. And bigger jaws, especially in the male, which is supposed to be the hunter or whatever, the bigger jaws tend to be the traits that have been selected for. So we should have bigger jaws because the biggest jaws people probably survived, and those are the genes that made it. Just like people that are that look at the negative, we tend to be more looking at the negative because the optimist was sleeping in the edge of the cave, right? And the pessimist was all the way at the end. So the pessimists, we tended to survive more, right?
Great explanation.
I look at everything. I'm an anthropologist by training, so I look at everything on an evolutionary perspective. But we also know that probably the snoring genes got eaten by a tiger in the middle of the night because the tiger found the one snoring and the one that was quiet didn't get fined. Right, so there's certain characteristics that should be selected for. And bigger jaws, we think there's an explanation why we should really have those genes in the population that's alive in the planet. And the fact that we don't have those big jaws, it means we haven't expressed them. But our brains know to be attracted to the Angelina Jolies and the bigger jaws. Our brain just says, this might be a better woman to procreate with.
Interesting.
And this is the attractiveness, which is not superficial. It's not superficial because how superficial is survival, right? And we have definitely an industry and a venality or vain industry, which is not something that scientists like to support, because we feel like it's what not how you look, right? And you don't want to judge people by the way they look. You want to judge them by their actions and their intelligence. But definitely this animal trait of your eyes and your smell choose who is going to be the best mate for you, and it's all about survival.
I find it fascinating. I think that I could see how you would get into a little bit of hot water talking about attractiveness, but what you're saying is this is more of like a subconscious signal that has been selected on purpose because it produces a better offspring, or an offspring with a higher chance of survival, instead of, scratch the term better, but it increases survivability of the offspring. So it makes perfect sense that a larger jaw would signal to somebody that this person is using their jaw, meaning they're eating regularly, meaning they're not going to starve to death. So that's a pretty darn good choice for a mate. So I could see that. Also, some things that we look for are like facial symmetry, because it's a nice indication that things genetically are going on properly inside of that person. So that's also in that realm of attractiveness. It's obviously not something that anybody can do anything about, but jaw size is something that we can do something about. And you talk a lot about in your book about the importance of chewing in these young kids, the importance of breastfeeding in these young kids. And you also talk about how using a traditional pacifier is counterproductive. So obviously it makes sense that the breastfeeding, using the suction, and then chewing are going to help develop that structure and help maximize its potential, to use your terminology. Explain the traditional pacifier being counterproductive, if you would.
Well, I don't think I've ever seen said the traditional pacifier is counterproductive.
Oh.
I do think a lot of breastfeeding. I think that's definitely the way we should do it, and it should be as long as possible.
Mm-hmm.
But that has to do with the muscles and the action and the pressures that we need in order to develop. The pacifier is interesting because every tool is good or bad depending on how you choose to use it, and also the time period that you choose. Because we even have anthropological evidence of pacifiers in very, very early societies. So having a pacifier is not a problem unless you use it wrong and you use it at the wrong stage. So ideally, and I learn a lot from my lactation consultants, and I know not to use a pacifier for the first couple of weeks until the baby has established a good latch that's latching well. Then we don't use it the first couple of weeks, but once the baby's latching and it's eating well and it has it's gaining weight and it's thriving and it's getting enough nutrition, having a pacifier is actually a good way for a baby to soothe himself or herself. So sucking is important. And the pacifier, I have lots of videos on this, especially because I've spent the last year designing a series of pacifiers for different stages. But you can see a baby, and when the baby is asleep with a pacifier, you can see that the baby has it in its mouth, and then it loses the negative pressure, and the baby starts sucking completely asleep. Mm-hmm. Suck until it regains that, we call that the uplock, mm-hmm. which is the resting pressure in a closed mouth should be about anywhere from 10 to 15 millibars of pressure, which is super light. Mm-hmm. When you swallow, and you can do it here, your audience can do it too, put your teeth together lightly and then swallow, and you create negative suction inside your mouth. If you swallow with what we call an invisible swallow, which is not using any of the facial muscles, and then right after you swallow, you stay in that position. That's what we call the uplock. And then when you swallow, it's about 100 to 200 millibars of pressure. It's a lot of pressure. And then you let go, but you only stay at 10% of the force you use for swallow, you stay. And then you can stay in that suction your whole night without any involvement of active force or energy expenditure. Mm-hmm. So the baby does this with a pacifier. And when you know the physiology, you know what's going on, you know that function, and then you watch a baby sucking on a pacifier, it's super clear that the baby is got the right sleeping suction, and then it loses the suction for whatever reason. And then it sucks again until it gets the right pressure, and then it stops. And then it's completely asleep, not using any expenditure of energy. The tongue is in the roof of the mouth, and then it might lose it again and repeat this cycle over and over throughout the whole night. So when you know what's going on, you realize that this is the right way. When the teeth start coming in, that's when you have to start weaning out from the pacifier, because a 6-8-month-old doesn't need to pacify himself through suction, because the baby will have so many other things that can use to soothe him or herself. So we have to understand every stage. This is also part of the transdisciplinary teams. I'm learning from a neonatologist, and they're telling me what each stage should be. And when you're 8 months, the baby should start, working on getting the nervous system to get the hand to the mouth, to the floor, to the table, and getting something into your mouth is super complex for your brain. And that 8-month-old should be doing that. So there's the baby-led weaning, as opposed to us feeding with a spoon or baby. The baby should be feeding him or herself. It should not be force feeding, pushing the food with, which is a soft, like a pot into the mouth, and then the food ends up in the face, and then cleaning it off and forcing it again, and fooling the baby by playing airplane or whatever, so that they actually do take the food that they're not ready to take. So we should really go from liquid to solid, and then to viscous.
Interesting.
We're giving babies viscous food because we're afraid of them choking.
Sure.
But a baby that has no teeth cannot choke, because and I have diagrams in our books, the pharynx, the entrance to the larynx is at the level of the ear. So a baby can swallow and breathe at the same time.
I remember reading that in your book. Very, very interesting.
And then an older kid cannot do that, and we cannot do that because our larynx descends, and then there's same tube is food on one side and air in the other. So then we have the epiglottis that covers it, but if we get messed up, we can choke.
Sure.
But a newborn cannot. So the pacifier is really not good or bad. It's appropriate for a certain stage and for a certain purpose.
Yeah.
And that's everything in life.
Spoken like a scientist.
Yeah.
Spoken like a scientist. I find it super interesting, this concept of the uplock, because I think what you're referring to there is the tongue being locked against the roof of the mouth. Now, you talk about the tongue as a placeholder and as a critically important component in oral posture. Can you expand upon that?
Look, posture for me is most important, more than function, because one of them is short time and it's strong forces, and the other one is longer time and very light force. And they're complementary. Obviously, we need good function, we need good chewing, but then we're going to spend more time resting. When we're asleep, when we are doing nothing, that's posture. And it's more relevant towards growth and development than function. And people are obsessed with this chewing, which is important. Obviously, you need that force. But I'm obsessed with posture. What do you do when you're doing nothing? And when I discovered the Dr. Engelke's work, I coined the term uplock, because we're trying to find a term that would show something that's up and it's locked. And Dr. Ehrlich is a pilot. He used to have his own plane. And the pilots have this term with the wheels. And when a plane is on the ground taking off or landing, it uses mechanics of solid bodies. And when the plane is in cruise altitude, uses very little energy and flies by dynamics of fluids. And these are complementary. The mechanics of solids, the mechanics of fluids. The tongue is actually a fluid. It acts more as a fluid, because it's like I was telling you the other day, if you have a glass, the fluid takes the shape of the glass. If you put water in a glass. Same thing, the tongue is a hydrostatic organ that can change its shape, but not its volume. So it will take the shape of either a narrow mouth or a bigger mouth. And if can't change his volume and there's not enough room in the mouth, the rest of the tongue or some part of the tongue will live in the pharynx, in the back of the throat. And that's apnea, that's snoring, that's not good function.
Sure.
And this happens when people don't breathe well. They can't hold this position when they're young. And as adults, we say, hey, you have to retrain your tongue. Well, nobody's going to retrain their tongue. You got to make the room and then just learn how to hold that natural position, just like a suction cup on the window. And we use the term from aviation, uplock. I don't know if it's clear, but we even started with Dr. Engelson, the Uplock Academy, because we thought it is so important to understand how this term and this position is the key to health. And so we even started an academy with that name, just to make people understand that if you can swallow, you can generate this suction. And if you learn and recognize it, and you practice maybe 20 minutes a day before you go to sleep, your brain will say, oh, this is nice, just like when you were a baby. If you have the right morphology, if you have the right shape, if you don't have the right architecture, like a home, like a room, you'll never get that couch if the room is not big enough. But we can make the room big enough. We have every technique because we have great orthodontics that you can do before the age of 3 or 5. Then we have still expansion. Then we have now there's a fad of this MSC with the implants, which I don't like, but it's you know an alternative. And then we have orthodontic surgery, which I've had myself, and it makes the room. And once you make the room, then you can train the tongue, and it's easy. If you try to train the tongue and tell the tongue what to do, you will fail every single time.
If you don't have the room, you're saying.
Yes, you got to make the room first.
But if you have the room, then you can practice this uplock technique on your own.
Yeah, so and it's not like exercise of repeating something. It's recognizing something. And once you recognize, you're aware of the suction. And it comes a point where if you just are aware of it for a period a day, then it just happens by itself. And
so I can relate to that very much.
Remember, we started this conversation by saying we do all these things and then they don't maintain themselves.
Sure.
But the tongue can maintain that size of the room.
Well, I think it's interesting, this uplock concept. And I think it's also interesting that you're saying that this is like the most powerful thing that a person can do for themselves. I think that everybody can relate to some extent with what you're saying about the tongue being hydrostatic in nature, in that it can kind of change shape. So one of the things that we were taught, in diagnostics 20 years ago, is to watch for scalloping of the tongue. When there's not enough room for that tongue, the teeth create indentations in it. And that's exactly what you're talking about. But this uplock is fascinating to me because optimal body posture is the posture of the least muscular effort. We're looking for the most efficient position to be in because the body wants to minimize energy expenditure wherever it can. And so you're drawing the exact same parallel with oral posture, which is this uplock concept where the negative pressure is holding the tongue against the roof of the mouth, not active muscular effort pushing the tongue upward.
Absolutely.
Super interesting. So to achieve that, you're saying tongue to the roof of the mouth, swallow with no facial movement whatsoever, correct? And then just be aware of how that feels because you're actively creating that negative pressure, which sucks the tongue harder against the roof of the mouth. Because when you instructed me, I felt it. Very, very interesting.
You need to be able to recognize it. And so I had to go around the world to find the uplocker and make it because it had been available 2003. Nobody recognized it. And then I had to go and make it. And it is available on my site. And it has a little bubble that tells you if you have the right pressure. And everything, the story is more complicated than we think, because you have to learn to hold very light pressure. Most people that do what we just did will hold too much pressure. So today I was in the clinic working with elderly people, and it's so exciting because they're getting rid of their CPAP. And they have tiny, tiny jaws and crooked teeth. This is in Germany where everybody has bad teeth. And they're getting rid of their CPAP by training this with Dr. Engelke. And my head is exploding because I would never think these elderly people can do that. But he brings them to the office and with a manometer shows them how to hold light pressure. And they sit there in their chair and they hold the manometer for 20 minutes and then they go home. And we saw so many patients and they say, you know, I'm not using my CPAP anymore and I'm sleeping better. And with the size of jaws that they have, I'm like, this is amazing that they can actually get rid of their CPAP. I got to look closer into this, but it is exciting to have now the tools so you can recognize it, because you got to recognize it. But without the manometer, and this is what Lord Kelvin says, I have that phrase on my wall. It says, if you can't measure it, you cannot improve it. And it's so true. If I tell you to do something, but there's no number associated with it, you will never improve it. And the manometer will tell you, you swallow, you see 100. And then you say, okay, hold it there. And you see 80. Let go a little bit, and then you see 4. And if I'm not looking at the manometer, I cannot lower it to 20.
So you're getting biofeedback while you're doing it.
Yeah, and so the manometers are fantastic. And I'm obviously going to have them available, but you can use any manometer commercially sold anywhere. But yeah, I'm just finding different ways. Like I said, I'm not going to blame my patients. If they're not successful, it's because I didn't give them the correct tools.
That's beautiful. And I agree completely. As a clinician, you're the one who's steering the boat. So if it doesn't get to the destination that you're looking for, you know exactly who to blame. That's exactly how I practice as well. We haven't even mentioned orthodontics yet. So talk a little bit about orthodontics and how it differs from orthodontics.
Well, orthodontics was just a term that I coined, and I actually had to take orthotropics out of my book because Stanford was very adamant. They did not want that term.
Why is that?
I mean, I'm not going to enter into details. Orthotropics is a fantastic philosophy, and it works for children, but I don't think it works for adults, and a lot of adults are looking for miracles, and this has become a more controversial term, and I had to get away from that term, unfortunately.
I see.
And I had to find something that described. I do think that the words that you choose define you. So I always look at what do I want to achieve? And I always said, look, if you can use any device you want, because people say, oh, my device does the same thing, and I use this. And I said, if you put a carrot in front of your nose, and that brings your jaws forward, I'm happy with that device. Let's use the carrot and give it to all the kids. And I said, I just want the jaws forward. And I coined orthodontics. So anything that helps your jaws develop forward is orthodontics. And it just means that our therapies are geared towards bringing everything forward. And it's very descriptive. It's not necessarily a technique like, you can't go to school and learn orthodontics and get a degree in orthodontics. But you can be inspired by the work that we're doing and the clinicians that are doing tremendous work. And it's not my stuff, it's not a single person stuff, but it's a transdisciplinary team that's doing things that are taking our patients forward in every single way. So I call it orthodontics, and I've set up protocols that you can follow. The one thing we haven't talked about is the nose. And my new book that I'm writing is called Nose, capital N, capital O for nitric oxide. I'm writing this with Dr. Ehrlich. And we're finding, we're researching on the nose. And really, the nose is a key element. Because if the nose is not working 100%, everything else will fail. That's part of our orthodontic protocols. We have 5 pillars. And It's nose is first, then posture, then expansion, then your bite. Make sure you have a nice bite and you're chewing on both sides, and then the vacuum inside your mouth. So those, and it's a hierarchy, and they're sequential, which means one has to be before two and two has to be before three. So 2 and 3, like posture and expansion, can be simultaneous, but everything else has really their own timing, and you have to follow those protocols.
So is it fair to say that an orthodontist is more concerned with just the alignment of the teeth and creating a nice smile, whereas somebody who subscribes to a forwardontic philosophy is interested in the functionality of the human, optimizing their ability to breathe properly and oxygenate their body?
Yeah, I mean, I'm not very good at tooting my own horn, and I don't want to say, that's what it is, because there's orthodontists that are fantastic and they're looking at the full picture.
Sure.
And they're still orthodontists, and there's orthopedics, and there's those things overlap. It's not as clear as you're looking at the body or you're looking at just the teeth. Yes, the term, like I said, the words you choose define you. Orthodontics is straight teeth, and those 2 words are going to define the more important thing that you do, the core of what you do. Forwardontics is anything to bring you forward, and we can use the real sense of the world going physically forward, but we can also use the spiritual part of it, of improving yourself by going forward. So I do think it's a term that's in progress. It's not defined, it's changing, but it's adding to something that's part of orthodontics. I do consider myself an orthodontist. I love my profession. I think it's the best profession on the planet. We deal with the cream of the crop, and we're not dealing with sick people. We're dealing with healthy people that want to be better, that are interested in their well-being, and our patients come in super motivated. My ENTs in our transdisciplinary, they complain because they say, when the patient goes to the orthodontist, he says, I'm ready, put the braces on, I'm ready, do whatever you want to do it now. And when they go to the ENT, they say, I don't want to have surgery, I don't want you to do this, I'm not ready. It's like they don't want to do everything. And when they come to us, they're ready to do everything. So we're lucky we have the patient in the chair and we can talk to them for hours. The ENT doesn't have the patient in a chair, and the patient is afraid of them. And the people that come to us are excited to come to us. So it is a great profession, and forwardontics is just improving on a great profession. And it's not that traditional orthodontics is one thing, and we're doing alternative orthodontics. We're just doing the same techniques, but way earlier. We are dealing with 3-year-olds with the same tools. We're still using wire and acrylic and the same tools we were using 100 years ago, but we're using it on kids that are very young. So we're getting different results because of the timing of the tools that we choose to use.
That's a very good way of explaining it. One thing that I'd like you to talk about that you mentioned in your book that I found super interesting was the teeth clenching as a result of premature contacts. This is a term that I had never heard, and I suspect my audience is not familiar with. Can you explain it?
Look, first I want to congratulate you on this beautiful interview, because you gave me time to talk. And as my ex-husband would say, I love to talk. But you're really letting me talk about what I find interesting, and you're not guiding me to what you find interesting, which is really unique. This is a great interview.
Thank you.
And you're really you're up there with Howard Stern and Marta de Baile and the big guys.
Now I'm going to blush.
Yes. But yes, I was waiting for you to go into the bruxism and the pain, because I know your audience is interested in
I'm
that
telling
topic.
you have 1,000 or more people on the edge of their seat waiting to hear why they're grinding their teeth, and I've never heard this explanation from anyone else.
Well, what happens is that if our teeth are not in contact during posture and we separate them, we have micro extrusions. The teeth will move. And any dentist or anybody that has ever lost a tooth will know that if you lose a tooth, the opposing tooth will grow into that space. So teeth are erupting our whole life. We don't notice that they're erupting because they have partners and they continue to erupt and they go forward. If we keep our teeth apart, even a little bit, for long periods of rest, then some of these teeth will erupt, and they're not going to erupt at the same rate. So some will erupt, and then when we bite down, there will be that tooth that hits a tiny bit early, and we won't know that, we won't recognize it, but our brain will, and it will grind it down so that all the teeth now are touching together, and we will continue doing that. That's only part of grinding. That's physiological grinding, and it wouldn't be a problem. But then we have issues with, when you hang your mouth open, things start falling down, and that creates less space for your tongue, less space for the airway, and your brain wants more space. So grinding is almost always related to a poor airway. And everybody that grinds is trying to open the airway, especially children. A lot of children grind, and they grind a lot, and they're trying to open their airway. Because when we close our teeth, our tongue gets trapped, and it has to sleep in the back of the tongue. So we have to open our mouth to allow the tongue to spill over the teeth. And when we close, again, we get those premature contacts, because the airway is, if we close the teeth and keep them the way we have to, the tongue cannot hold it. So if you have somebody that doesn't have a good jaw, and you ask them to keep the teeth in contact for a long period, they won't be able to, because then the tongue has to be in the back of the throat. So when we take pictures in orthodontics, sometimes we take the side view. And on children, I remember before I knew all this stuff, we knew we had to click really fast. We said, okay, well, I'm going to say 1, 2, 3, put your teeth together and click. Because if you don't do it fast, the kid would open the mouth, and you always get the picture of a little bit open of the teeth. So we know that you can't keep your teeth in contact if you have an airway issue. And it's kind of a vicious circle, or a chicken and egg thing, because you will have the teeth apart will cause less room to breathe, and putting them together will keep you from being able to breathe. So you have to separate the teeth. And we've actually looked at this with an endoscope, where we look at the pharynx, and when teeth are together, the pharynx gets closed, and then you ask the patient to swallow, and then the pharynx opens, and you can see it with an endoscope.
Wow.
So we've actually looked into this stuff. And then that also relates to joint pain.
When the teeth are closed, it opens the airway.
No, when the teeth are closed, if you don't have enough room and you try to close your teeth, it will close the airway. Because imagine you have, a big Jack in the Box or something inside the mouth. If you close it, the extra part will live in the back. If you split the teeth, the extra part will be in the front, so your airway will be open.
So this is all based on a jaw that doesn't have enough space.
Yes.
Okay.
If you keep your teeth together since you're a baby, since the teeth erupt at a year old, and your teeth are together lightly in the tropic premise, which is described by John Mew, and you have that position for at least 4 to 8 hours a day, then your teeth together will continue to expand your jaw, and the tongue will put that light force so that your jaw continues going forward. If you keep your teeth apart, for whatever reason, there's tons of reasons to keep the teeth apart. It could be that you're not breathing well, which is the most common reason, or it could be that you have a cavity and it hurts to put them together. So you start hanging your mouth, and you can have a mouth open with lips together. So if your teeth are apart, that technically your mouth is open, even if your lips are together. So if that's the case, then you will develop in that way as you're growing. And there's a drawing in JAWS in the book, which is very interesting, because if you at rest your teeth are apart, then your joint will be comfortable in that position. And so every time you close, when you're fully developed, you will be pinching the meniscus of your jaw. So the way to treat people with jaw pain is to give them something either enlarge their teeth, make them longer, or give them a splint that actually opens the vertical dimension. And that will help them with pain because they will not be pinching it. And that's why the treatment is to enlarge, make the teeth longer, or the splint. So if you have a good position when you're little and your joint develops in a good position, then you can keep your teeth closed without any pain. However, if that falls apart and it's not right, you'll either grind down to try to find that position, or you will just stay with your mouth open, or both, and you will have pain. Every time you chew, you will be hurting your jaw.
Wow. So the premature contacts, for an outsider looking in, I think people would understand it if we talk about it in terms of the carbon paper that a dentist puts in your mouth to check what's contacting first, right? And then they go in manually and try and eliminate those premature contacts. So what you're saying is that for a lot of people who have these bruxism or clinching problems, they're sensing areas that are coming into contact that would show up on that carbon paper, and they're actually trying to grind that down on their own. That's right?
Yep.
Amazing. Amazing. Now, the part that you added there about the teeth open and the teeth closed and the tongue position fitting into that puzzle is incredibly interesting. Because again, it's like expanding the picture. It's not just the premature contacts, because the tongue still has to go somewhere and the jaw still has to be able to accommodate the tongue. Otherwise, it slides backwards, or it has to come forwards.
And when you talk about pain, it's very easy to see the patterns that will tend to develop pain. And we call the class 2 division 2, which are the people whose teeth are angled in. And they deep.
Like if you saw their front teeth from the side, they would be this way?
Yeah.
The top ones. The
top, yes. And, you know, the type of nice, they look well developed, like Jacqueline Kennedy type of nice jaw that's a little deep. We even call it the cheerleader look, because a lot of these women are very attractive, and their teeth are in, and this part of their face is shorter. So it's the opposite of a longer face, and they tend to develop a lot of pain. So when you see these patterns, and they have more, it's more evident on men that have very strong masseters. They tend to be more bruxing, and it's again chicken and egg. They're bruxing, so they're working those masseters all the time when they're at night. So they're going to have this pattern. But it's also, you have a muscular pattern. There are people that tend to be more lengthy, more, we call it brachiocephalic, and we have the dolichocephalic, which are the lengthened. And also when you have the very, very roundish chin that goes back, and those tend to have resorption on the joints too, and joint problems. So when you look at someone, if you're a pain doctor, or you've seen a lot of patients with pain, you can tell just by the facial features the type of patient that will have pain. And it's those two, either the one that's very deep, or the one that's really rounded and has, you know, a chin that's back. Those are the two very typical pain patients. And they're hard to treat because the muscles have years of patterns that can't be changed. And at that point, there's a lot of just palliative care, and opening the bite helps one type, and other patients even have to have replacement of the joints, because the joints get really resorbed on those patterns where the chin is down and back. And it's hard for them to deal with their pain. Of course, everybody's different, and sometimes you see some that have where they really have been able to compensate, and they don't have pain. But the ones that have really bad pain, they have either of those two patterns. I'm not a pain specialist, but I've seen so many patients throughout my 40 years of doing this that I can recognize, and I have a lot of empathy for chronic pain, because it's difficult, and it takes your energy away.
Sure, it does.
It's very, you can say, you know, work out more, get up earlier, but if you're dealing with chronic pain, drains you, and it's hard to get out of that circle that will get you out of pain.
Yeah,
So,
well, the explanation that is rampant for bruxism and clinching is just stress, and the mouth guard is not a great solution, because you find that 1/3 of people get better with it, 1/3 of people get worse with it, and 1/3 of people it does nothing for. So, but that's kind of interesting because it fits into what you just described based on the different facial structures. It makes perfect sense that a different facial structure would need a different solution than another person, and not all teeth clenching is the same. One last thing that I want to ask you, Dr. Kahn. In our previous conversation, I showed you a jaw training device that I was using, and you went, "Oh, it made me shudder." You have to explain why that's the case.
look, I don't think we need more forcing things. I think the opposite. We need to develop that negative suction that's super biological, and that your body is recognizes as a resting position. We definitely need to eat hard food and exercise and all this stuff, but I don't think that's really, I mean, I think people are overdoing all this chewing. I do love chewing gum. I think it's good because you have to chew on both sides, but just those things they just don't look conducive to anything good, in my opinion.
That's okay.
But
I
all
love
that
your
said,
reaction.
this might work for some people. For me, I wouldn't even try it because it doesn't make any sense. For me, it has to make sense. It has to look logical. And for me, all this going overboard with exaggerated chewing is not, doesn't make sense to me.
Well, I think that the people watching this are going to resonate very much with your concept of keeping the mouth closed and achieving that perfect resting oral posture using suction instead of muscular effort. I think it's very nuanced, and from what you're saying, one of the most important things that a person can do to help have proper function of their teeth and their jaws, and to breathe properly, which leads to better outcomes across the board.
Yep. And there's everything's connected. So if people have pain or grinding, if they work on their airway and their airway gets better, I see that everything else gets better too.
If you want to do a deeper dive into this subject, I highly recommend picking up a copy of Dr. Kahn's book, Jaws, The Story of a Hidden Epidemic. You can find that anywhere that books are sold. And if you want to know more about Dr. Kahn and the cutting edge work that she and her team are doing, go to forwarddontics.com. I'll put links for both of those in the description underneath this video. Thanks so much for watching. I really appreciate all the support, and I'll see you next time.